My name is Jeff Fineman. I'm originally from New York, where I did most of my medical school training. And then I moved out here to University of California, San Francisco, where I trained in pediatric critical care medicine. And I started my research career at the Cardiovascular Research Institute here. I do ICU for a living, predominantly cardiac ICU. I run the ICU here at UCSF, Benioff Children's Hospital. I'm also now a senior investigator at the Cardiovascular Research Institute. I kind of got started in the pulmonary hypertension world from a research perspective. I mean, Abe Rudolph, who was one of my mentors originally, was really the first person to describe how blood goes through the lungs in the fetus, then how it changes dramatically at birth, and started out with basic physiological studies, and then kind of got into pediatric pulmonary hypertensive disorders in the lab with particular focus on pulmonary vascular disease related to congenital heart disease, because that's what I was taking care of in the ICU setting. Then I met Ian Aditya when he came to run this cardiac ICU at UCSF. And I saw that he introduced me to outpatients, which I hadn't done in a very long time. And then when he left to go on to Edmonton, I started the pediatric pulmonary hypertension service, which is basically just kind of continuing what he did and then expanding it. And so we started that in 2012. So now I take care of pulmonary hypertension patients, not just in the ICU, but obviously in the outpatient setting, and follow them. But all of this for me really started from a research perspective. That's how I got involved in it. The draw for me for research is I see that understanding basic mechanisms is really where you could get target therapies. And it can't be too far away from the bedside to keep me enthusiastic. So, I mentioned congenital heart disease, and because that's what I was taking care of in the kids. And it was at a time when there was a lot of morbidity and mortality related to perioperative pulmonary hypertension in congenital heart disease. So it was a real significant problem. I was very, very fortunate that early on in my research days, I was interested in the role of this endothelial function or dysfunction in pulmonary hypertension, and started studying something that we called EDRF, or endothelium-derived relaxing factor, that turned out to be nitric oxide. And so because of my work, when Warren Zapol first kind of started using it in animals, he called me and got me involved in the very first clinical trial of inhaled nitric oxide for newborns with pulmonary hypertension. So very early on in my career, I got to see translation from the lab to the bench, from the bench to the bedside, which was really exciting for me. And I think that's what's kind of kept me in the game in terms of trying to understand mechanisms of disease so we can, design better targeted therapies for the diversity of pulmonary vascular disease. As you know, it's a rare disease, and it's a spectrum of disease. And really the way we're going to learn about things is trying to learn from every patient something. And really the only way to do that is to collaborate and try to get together in a multi-centered way. I think the great paradigm for that is the cancer groups, where basically every patient is put into a protocol. And from there you can see, acute lymphoblastic leukemia, for example, in childhood is almost cured. And it's because of those type of efforts. That's what we need to be doing in pediatrics. If you look at survival, obviously now compared to before we had these drugs, we're doing fantastic. I mean, it's great to have these different types of agents that we use, particularly for kids, where you can maybe give them a suspension, et cetera. I'm not minimizing what has advanced, and it's really dramatically changed the playing field. There's some game changers here. Having said that, and again, not to minimize the advances we've made, I see us where maybe cancer was 30 or 40 years ago. You talk about adult versus pediatric, I would say the way we talk about pulmonary hypertension or pulmonary vascular disease in general, it is such a spectrum of disease. It's like calling a 40-year-old woman with breast cancer and an 80-year-old man with prostate cancer as just the same, they both have cancer. And we clearly know that they're very, very different diseases with different pathobiologies and require very different therapies. And so I'd say we have a long, long way to go to learn about, even within just the classifications, what are the real mechanisms of disease related to congenital heart disease? What are the real mechanisms of disease related to toxin-induced pulmonary hypertension? What are the mechanisms of the disease related to infections or idiopathic in a 10-year-old versus idiopathic in a 40-year-old? And really kind of get towards personalized medicine, where if we can understand the differences and where the pathobiology lies, then instead of this child's pulmonary hypertension is not too bad, we'll give them one drug, one of the classes. It's pretty bad, we'll give them 2 drugs, one from 2 different classes. Or it's really bad, we'll give them 3 drugs, one from each class. And I don't mean, again, to minimize, it's dramatically changed things. But I think we've got a long way to go. And say, okay, this particular patient at this age with this particular type of pulmonary vascular disease with this particular genotype, we start here, and then if that doesn't work, we add this. That's where we need to be. But there's a whole other area, the smooth muscle cell proliferation, et cetera. There's many other targets down the road that I think we can get to where drugs can be designed that continue to change the face of this disease. Very exciting time. Very exciting time.